Good evening, everyone, and a warm welcome to this session. We're going to be having a free class being conducted by one of our facilitators and tutors at Passcode Global Consultants, Roslyn. And before we get to the session, I'd like to um, share a few things about Passcode and what we do. So, welcome all. I know some of you are already with us, some are just joining in for this session. And yes, so what Passcode Global Consultants is a firm, an end-to-end support solution for all nurses, in especially if you're looking to move from Kenya and move to maybe the US, Germany, and all other places for work, Passcode is a place to be at. We offer end-to-end support to our nurses from the time they start registrations for Nclex to the time they sit, and even up to um, we up to connecting you to an employer in your preferred country of movement. This is going to be an Nclex class, so I can focus on what we do for Nclex or nurses who want to move to the US and Canada and Australia. So currently, we help nurses train for NCLEX. On top of that, we also help you with your registration process as you plan to move. If you're going to the US, we do that. We do help you with your registration. We also help with those who want to endorse their licenses to other countries. For example, you are licensed in the US but have an employer in Canada or Australia, we can help you with all of that. We also have regular intakes. Today's class is a sample of what we do every other day in our classes, especially if you're looking to do your NCLEX and have not yet started a class. Our classes look like this, or they are structured the way this is going to be structured. So we have intakes, and our next intake will be on the 10th of August for Nclex. So if you're looking to start your Nclex journey, you can reach out after this, and one of our people will reach out to you. So about Roslyn, Roslyn is one of our tutors. She has worked with several nurses who want to move in terms of training them. She has also worked with international companies locally and abroad just to come up with a curriculum, or she's a curriculum facilitator especially for the NCLEX. And we are so glad to have her on our team and even to have her for this session. So if Rosalind, you can hear me, I'm going to have you go ahead and start the class. Thank you.
Thank you very much for the invitation, and hello to everyone. I hope you can hear me. Just let me know in the chat box if you can hear me as I share my slide. Kindly inform if you can hear me. Also, let me know if you're able to see my screen. Let me ask one more time. Are you able to hear me? Also, let me know if you're able to see my screen. Kindly give feedback on this before I start. You can let me know in the chat box. Ruth, are you able to hear me? All right, thank you very much for honoring our invitation and joining this free Nclex review topic. Today we're going to discuss about fluids and electrolytes. So we're going to look at the following objectives. We shall start off by discussing the causes, the assessment and management of fluid deficit and overload. And I believe that you're going to be active. Active means that at least when called upon to give feedback, you're able to do so. Okay? Because it's supposed to be an interactive session, not only one person doing the talking. Also need to gauge if you're following through. Secondly, we'll discuss the types of IV fluids. And then thirdly, we'll discuss various electrolytes. So depending on how time will be, we'll do a few, if not all. So we look at the normal values, some of the causes, both of high and low, and then you have the assessment, and lastly, the management. So with this, we have some electrolytes like potassium, we have sodium, we have calcium, magnesium, phosphorus. So depending on how time will allow us, we will to do a couple of them. So I hope you're set and ready to learn. And as I've said, it's an interactive session. Should you have any questions, any concerns, if called upon to answer a question, feel free to do so. All right, so we're going to start with the first objective, and that has to do with discussion about fluid deficit and overload. And we'll start with fluid volume deficit. So fluid volume deficit, this occurs when the body loses more fluid than it takes in, leading to decreased circulating blood volume. And with that, there's a reduction in tissue perfusion, which can progress into hypovolemic shock. So the Nclex, you're likely to be tested on the assessment, that is the signs and symptoms, or some of the causes. So you have these causes, and it's not the only list, but the major causes include loss of water exceeding fluid intake. For example, dehydration is one of them. Okay, when someone is not drinking enough of the fluids, it could arise from gastrointestinal losses through vomiting and diarrhea, severe burns where fluid will shift, and that also can lead to damage to skin barrier. We also have hemorrhage where there is loss of blood within the intravascular volume. Age is also another factor because we know that as one ages, then there is a decrease in water stores, the decrease in thirst sensation, the reduced in terms of how the kidney function. All those coupled up will cause dehydration. And then you have some conditions like DKA, that is diabetic ketoacidosis, where one presents with high blood glucose, which causes anosmotic diuresis. And then last but not least, we have the use of diuretics. So when someone is using a diuretic, an example is furosemide or even hydrochlorothiazide, you'll find that these medications will lead to increase in urine production. So how does an individual present whenever they're experiencing fluid volume deficit? So first and foremost, we have weak, ready pulses. So if you're asked a patient with dehydration and they indicate that they have +1, +1 relates to weak pulse. What is the normal pulse in terms of the strength? So this is weak. When it is normal, what do we write? What do we document when it is normal? Still waiting to get your feedback. When the pulse is normal, how do we document that? Not in terms of the rate, but in terms of the strength. So I'm saying +1 is weak. Or about when it's normal? Okay, so it's normal. It's documented as 2 plus. This is normal strength of the pulse. We talk about bounding, we talk about increased. We have 3 plus for increased, and then you have 4 plus for overload. So you may find someone has written a pulse of 101 beats per minute, and then they go ahead and write 1 plus. Okay, so it's weak. And then also another assessment include weak and fatigue. They present with orthostatic hypotension, poor skin tagger, capillary refill that's more than 3 seconds. Also, they have poor urine output or low urine output. And the urine that comes out is dark and concentrated. And some of them will also experience weight loss. So how do you manage uh, this? Of course, we need to replace fluids and electrolytes. So fluids can be replaced depending on how much has been lost. It can be replaced by oral or intravenous, that is giving normal saline. And as you do this, you also need to monitor the electrolytes, in particular sodium. For patients who are vomiting excessively, you also look at potassium. Other thing that we say that they normally lose weight, so you also need to do daily weights using the same scale at the same time, wearing the same clothes. And then also need to perform strict monitoring. You monitor the intake through getting or capturing any fluid the patient has taken. That include IV, orals, even via the NG, including the irrigations. And also you monitor the output. That is either vomiters and even suction. So here the underlying indicator is urine output. So ideally, the patient should at least have 30 mils of urine output per hour. To be precise, we talk about 0.5 mils per kg per hour. So that's about fluid volume deficit. Now we want to look at the opposite, and that is fluid volume overload. What can bring about fluid volume overload? What can cause this? I don't know why the class is not participating. I like an interactive class. Nobody seems to be answering anything. I don't know if you're able to hear me or not, but I believe that you're following through, because sometimes if someone is just presenting continuously, you're not able to gather if people are following through or not. Okay, thank you for those that are responding. Uh-huh. So we talk about the fluid volume overload, and this one occurs when the body retains more fluid than it can eliminate. And that leads to increased circulating volume and accumulation of fluids in the tissues. You may see a patient presenting with edema. So we have some causes, for example, renal failure, and that's the most common cause of fluid retention. In addition, you also have liver cirrhosis, whereby it causes impaired liver function and altered fluid regulation. You see patients with liver cirrhosis, they tend to have what we call ascites and also peripheral edema. You also have burns. Severe burns can cause fluid shift, leading to fluid overload during treatment. In addition, you have excessive intake, whereby when someone is taking more than the body is able to remove it, including when you perform excessive IV fluid administration or drinking excess. Also, you have long-term steroid use. Steroids, they promote sodium and water retention. So, for example, a patient taking a corticosteroid for long term, you may find them presenting with hypertension, weight gain, and even edema. We have a condition that is called SIDH, that in full is syndrome of inappropriate antidiuretic hormone, where there is production of excess ADH, which causes water retention. So all these are part of the causes of fluid volume overload. And the key one I've said is renal failure. So the signs and symptoms include pitting edema. We have crackles, respiratory, bounding pulses. And I said for bounding pulses, we document them as either +3 or +4. Actually, +4 because 3 plus that is increased and then bounding is 4 plus. Also, one has distended jugular venous distension, and how you assess for that, they always have to tilt at a 45-degree angle. They present with hypertension, so their BPs would be elevated, and their central venous pressure will be elevated as well. That is more than 8, the normal being 2 to 8. And due to fluid retention, some of them will also present with weight gain. And then on the management, we have the administration of diuretics as prescribed. Diuretics are going to promote kidney excretion. So give me examples of diuretics, though I'd mentioned them earlier. Examples of drugs that belong under the diuretics classification. Yes, you have furosemide. Besides the furosemide, which other one are you familiarized with? We also have hydrochlorothiazide. Hydrochlorothiazide. We also have spironolactone. So all those are examples of diuretics a patient can take. And then also you have the fact that we need to restrict sodium and fluid intake as prescribed. So we restrict sodium to reduce water retention. Remember, water will always follow sodium. We restrict fluids to prevent further fluid accumulation. And you'll find this a lot being done for patients who have heart failure, patients with kidney failure. So for a patient who experiences thirst and they're on strict fluid intake, what we need to advise them to do is to chew on a candy, okay? That will help in managing their thirst instead of taking water because it is restricted. And then lastly, you need to monitor the electrolyte values because as a patient develops fluid overload, it can also lead to electrolyte disturbances. For example, sodium may be low in a condition like SIDH. Okay, potassium may decrease with some of the diuretic that you may use, the potassium esters. Also, you need to assess their creatinine and BUN to assess for kidney function. So those are the two discussion about fluids. And so we want to move to the next discussion that's about the types of fluids. So the types of fluids, they are widely categorized into 3. The first category is the isotonic fluids. We have the hypertonic fluids, and then you have the hypotonic. So we'll start with the iso. Iso means with the same concentration as blood plasma. Same concentration as blood plasma. That is similar to 0.9% of normal saline. So with this isotonic, we're saying it has same concentration. They do not cause significant movement of water into or out of the cells. Rather, they just expand the intravascular volume. So mainly they stay within the bloodstream. Okay. So examples, we have the 0.9% normal saline. We also have lactated ringas, or some of us, we call it ringas lactate. The US, they refer to it as lactated ringas. And then we also have another one that is 5% dextrose in water. So one thing about it is usually initially isotonic. That is within the bag. Within the IV bag, it is isotonic. But the moment you infuse, then glucose is metabolized, leaving the free water. Okay, so inside the body, it functions as hypotonic. That is very important to remember. In the bag, it is iso. The moment you administer it, glucose is metabolized and then it becomes hypotonic. Second category, we have the hypertonic. Hypertonic. That means they have higher concentration than blood plasma. That is more than 0.9% of normal saline. So what do? They pull water from inside the cell into the bloodstream. They pull water from inside the cell into the bloodstream. So examples, we have the 3% sodium chloride, we have the 5%, we have the 1.5, you have 5% in normal saline, we have 5% dextrose in RL, we have 10% dextrose in water. All those are examples of hypertonic fluids. So remember, what they do, they pull water out of the cells. And then last but not least, we have the hypotonic fluids. So this one, they have a lower concentration than the body plasma, which is equivalent to 0.9. So it's less than 0.9% of normal saline. So what they do, they move water from the bloodstream into the cells. They move water from the bloodstream into the cells. So they hydrate the cells. And as you do that, then you'll find they will cause a decrease in intravascular volume. Examples, we have 0.45% sodium chloride, also called half normal saline. And that's the most common used hypotonic fluid. Patients who are experiencing hypernatremia, patients with cellular dehydration would be put on 0.45%. Other examples, you have 0.33%, 0.2%, 5% dextrose in water. Remember I said that one, it is isotonic while in the bag. The moment it is infused, it becomes metabolized and then it moves to become hypotonic. And then the last one is 2.5% dextrose in water. So something about the hypertonic solution, as you administer, you need also to monitor the blood pressure. A patient can develop hypertension because of the sodium content in it. Those that contain too much of sodium. Remember, water will always follow sodium. So this patient is at risk of hypertension. Other point to take note of is about the lactated drinkers. Remember, it contains potassium, and this one should not be administered to clients who already have AKI or chronic kidney disease. One of the things that you need to avoid in patients who have kidney diseases or kidney failure is hyperkalemia. And you're saying that Ringer's lactate contain potassium, so we avoid giving it in these clients. So in summary, these are the fluids and their uses. So for isotonic, I've said it can be used in when a patient has suffered blood loss because it increases or it expands the intravascular volume. During surgery, when a patient presents with dehydration, when there is fluid loss, as a maintenance fluid, also for clients who are NPO. That is for both normal saline and sometimes lactated ringas. Ringas lactase, we also have it being used for patients who have suffered burns. And then for hypotonic solutions, the use is primarily when you want to manage hypernatremia. Because I've said it moves water from the bloodstream into the cells. So patients who present with hypernatremia, patients who present with cellular dehydration, they'll be put on a hypotonic solution. And then thirdly, we have the hypertonic. The hypertonic, these ones, they pull water from inside the cells into the bloodstream. Okay. So widely, they're used to manage severe hyponatremia. Severe hyponatremia. So for them, you have to monitor for fluid overload, for pulmonary edema, and rapid sodium correction. So away from the fluids, now we want to talk about the electrolytes. And I'm going to start by highlighting the normals. So for sodium, the range is between 135 to 145. For potassium is between 3.5 to 5. And you know potassium is a key electrolyte to take note of. Highly testable, it comes to Nclex. We also have calcium, which ranges between 8.4 to 10.6. Magnesium between 1.3 to 2.5. We have phosphates between 2.5 to 4.5. Chloride between 96 to 106. And bicarbonates between 22 to 26. So you want to go through the key ones, and we'll start with potassium. And in particular, we shall be talking about hypo and hyper. So for potassium, when it's low, we talk about hypokalemia. Hypokalemia. So I want to ask, somebody's asking, do they provide you with the ranges during the exam? Yeah, the answer is yes. For currently, you'll be given the ranges. But even though if you're given, some of the cubans may not show you the ranges. There are those electrolytes that you must have on your fingertips, whether you have the normals or not. Like this one, you must have. This one, you must. Whether it has been provided or not, you need to know. Again, depending on what has been provided, you'll base your value given the reference. Okay. If the reference, for example, here they've indicated 136 to 147, that is the lab control value. You're going to use this reference. Don't go and say, this is what's supposed to be. So look at what has been given as the reference interval. So in many instances, especially for case study questions, the NGN, they'll give the reference. But for MCQs and maybe SATs, they are unlikely to give you the references. So you start with hypokalemia. And I'm going to ask, what are some of the causes of potassium loss? What can cause potassium loss? Some drugs, they do like the diuretics, the potassium wasters, when an individual is vomiting, inadequate intake. Okay, those are great responses from you. And so let us have that discussion. So while you're discussing some of these electrolytes, we're talking about the causes. We'll also go a step higher, discuss about the assessment, including those that affect the ECG. So for those that affect the ECG, we shall discuss about how the ECG appears, and lastly, the management. So hypokalemia. So you know that potassium is a major intracellular cation. It functions to regulate cellular water balance. It also maintains acid-base balance. So we talk about hypokalemia when the potassium is lower than 3.5. And you know this is a potentially life-threatening. Now, some of the causes of loss of potassium include some drugs that, like some of you had mentioned. For example, diuretics, corticosteroids, inhaled albuterol. And that's why you'll find sometimes when a patient presents with hyperkalemia, they tend to be nebulized. So nebulization brings about a reduction in potassium. So it can trigger hypokalemia. We also have conditions like Cushing syndrome, when there's aldosterone in excess, GI losses like vomiting, diarrhea, also gastrointestinal wound drainage, when someone undergoes prolonged suctioning from the NG tube, excessive sweating, kidney disease, where there is impaired potassium reabsorption, inadequate intake, when someone is fasting or on NPO status, movement into the cell, especially whenever you are managing or treating for hyperkalemia. We talk about shifting using insulin, dextrose, and calcium gluconate. It may lead to the opposite effect, that is hypokalemia. Then also you have dilution through water intoxication and IV therapy with potassium deficient solution. All these are just some of the causes of hypokalemia. And here you're saying it affects almost every body system. And so the signs and symptoms are classified based on the system that is affected. For example, in the cardiovascular system, an individual will present with weak, thready, irregular pulse. We also have slow, weak, irregular heart rate, orthostatic hypotension, a low blood pressure. We have dysrhythmias. In the respiratory system, it includes shallow, ineffective respirations due to skeletal muscle weakness. In addition, you also have respiratory failure from profound muscle weakness. And thirdly, diminished breath sounds. GIT is not spared. You'll find there'll be a decrease in motility. So a patient presents with hyperactive to absent bowel sounds. And this is one of the things that you need to monitor, especially for patients who are post-surgery. A patient post-op and they keep on vomiting. A patient post-op and they keep on vomiting. They're at risk of what we call paralytic ileus. Okay? They're at risk of paralytic ileus because they are losing a lot of potassium. And you're saying that hypokalemia contributes to decreased motility. And so a patient may develop this. So always ensure that your patients post-op are given at least an antiemetic to prevent hypokalemia. Nausea and vomiting, constipation, including abdominal distension. In the neuromuscular effects, patients present with anxiety, we have lethargy, confusion, they can even go into coma. In addition, we also have muscle twitching, cramping, paresthesia, that is tingling and numbing sensation, early signs. We also have skeletal muscle weakness and leg cramps, deep tendon hyporeflexia, paresthesia, and lastly, loss of tactile discrimination. All those, as you can see, there are more than one system that is affected. What about the ECG? The ECG for a patient who has hypokalemia, how does it appear? How does it look like? So we have ST depression, shallow or flat T waves, and you also have a prominent U wave. So a normal ECG normally looks like this, is the P wave, And then after that, you have the QRS complex, and then you have the T wave. So this is T, this is Q, this is R, this is S. So for a patient with hypokalemia, we would normally have another wave that comes after T, this one here. So this is the U wave. Okay? So a prominent U wave is a characteristic of hypokalemia. And then you're saying in addition, you also have ST, depression. This is the S, this is the T. So instead of it being here, it goes down. And also you have T inversion. So T should face upward, but in hypokalemia, the T faces downwards. Okay? Those are features that you need to be familiarized with, because you can be given an ECG of hypokalemia, then you're supposed to describe what is happening to that patient. Let me know if you're able to hear me. Are you able to hear me? Just confirm this if you're able to hear me. All right, so for those ones who cannot hear me, check on your connectivity. For those ones who cannot see my screen, also check on your connectivity. Now let's talk about the management or the interventions. So first and foremost, we need to monitor the electrolyte levels. In particular here, we're talking about potassium levels. Also administer potassium supplements, can be given orally or intravenously as prescribed. So for oral potassium, remember, it may cause nausea and vomiting, so it should be taken with food. For liquid potassium, it can cause amplification test as well, so it can be taken with juice. And then you need to administer potassium IV, and shall discuss more about it. It's never given us as bolus. On safety and medication, number one, this is a patient, you say they have reduced muscle they have muscle weakness. So you need to provide safety. You need to assist them whenever they are walking, and you assess for the risk of fall. For medication, you need to be on the lookout to discontinue any that will result in further potassium losses, like furosemide. So if a patient needs to take a diuretic, then you go for one that is potassium sparing. As a nurse, you can always be an advocate to your patient. On client education, you teach them about foods high in potassium. So which are some of these foods that are high in potassium? Let me get your feedback on that. Foods rich in potassium. So we have tomatoes, we have avocado, bananas, potatoes. Okay. So a patient with hypokalemia, this is a patient who needs to be put on a potassium-rich food. So here is a table that contains some of the foods that are rich in potassium. So we have the avocado, the pumpkin, pomegranate, bananas, the lentils, mushrooms, coconut, water, peas, watermelon, spinach, potatoes. All those are good sources of potassium. But remember, this patient, it depends with the level of hypokalemia. A patient whose level is way decreased, then they need to get it intravenously. So for IV, remember we said potassium comes in in different sources or forms. I mentioned about oral potassium. I mentioned about liquid potassium, and now we want to discuss about IV potassium. And this is given for a patient who has way reduced, and even if you check on their ECG, they are presenting with arrhythmias. So here you're saying that you should never give potassium by IV push. You can't give it bolus. You don't administer it IM, neither do you give it subcute. So the only route that is given is intravenously, but not as a bolus. Supposed to have an IV pump. So the recommended dilution should be no more than 1 milliequivalent in 10 mL of solution. So the IV solution preparation. So prepared IV solution with potassium are commonly supplied. Before and during infusion, you need to rotate and invert the bag to ensure that there's even distribution. Also, we need to ensure you label properly, including the infusion rate. So I've said that the maximum recommended infusion rate should be between 5 to 10. Should never exceed 20 milliequivalents per hour under any circumstance. As you give potassium, you also need to do monitoring. You monitor the cardiac. The patient needs to be on a cardiac monitor. So here you check on the ECG because as you give, you may lead to hyperkalemia. So an ECG tracing that will be different from hypo. Also need to use an infusion device to control the flow rate. Other thing that you monitor for phlebitis. So potassium infusion can cause phlebitis. So you need to access the IV site frequently for signs of phlebitis, for signs of infiltration. So if the two occurs, you need to stop the infusion immediately. Other thing that you need to assess even before you start the patient on this is their renal function. Because you cannot give a patient who has kidney failure potassium to lead to hyperkalemia. So you monitor the intake and the output throughout administration to ensure that the kidneys are functioning adequately. So these are very important facts to remember as far as Nclex is concerned. Next, we want to move to hyperkalemia. And just like you have done with hypo, we do the same for hyperkalemia. So hyperkalemia, this is when the serum potassium is more than 5. Sometimes you have what we call pseudo hyperkalemia, which can result from improper blood specimen collection. So for this particular case, retesting may be required if a patient does not have accompanying symptoms. So we have various causes of hyperkalemia, and these include excessive potassium intake. For example, from over-ingestion of potassium-rich foods or medications like potassium chloride and salt substitutes. It can also arise whenever there is rapid infusion of potassium-containing IV solution. As I said, as you give potassium IV preparation, you need to have an infusion pump to avoid this occurrence. Secondly, it can occur from decrease in potassium excretion. Patients with kidney disease, patients with Addison disease, patients taking potassium-sparing diuretics. And lastly, it can result from potassium shift from the cells into bloodstream. For example, during tissue injury, acidosis, hyperuricemia, and tumor lysis syndrome, a complication of cancer treatment. Now, on the assessment findings, and I said when potassium is elevated or reduced, it affects more than one system. So for acidosis, here I'm referring to, for example, in DKA, okay, where it may be elevated. So for assessment, in the cardiovascular system, we have dysrhythmias. We also have slow, weak, irregular heart rates, decreased blood pressure. In the respiratory effects, we have profound skeletal muscle weakness leading to respiratory failure. We also have neuromuscular effects, which are classified into two, early signs and late signs. For early signs, it includes muscle twitches, cramps, paresthesia, that is tingling, burning, numbness in the extremities and even around the mouth. For the late signs under neuromuscular effects, we have profound weakness, ascending flaccid paralysis affecting the arms, the legs, the trunk, the head, and respiratory muscles. And then for the GIT, we have increased motility, hyperactive bowel sounds, and diarrhea. So basically, it's like the opposite of what you have looked at under hypokalemia. So I may want to know, what are some of the ECG changes? ECG, what do you observe for when a patient has hyperkalemia? And do you know hyper kills faster? So as a nurse, if you get results, you need to be vigilant on how potassium is, especially the UECs. If UECs are done, please be on the lookout to see how potassium is. So when someone mentions about peak T waves, so that's a significant area to remember on the ECG. So I said a normal ECG looks like this, okay? So this is a P, this is a Q, R, S, and then you have the T. This is the T wave. So in hyperkalemia, we are saying one of the features is that there is a tall T peak, a tall and peak T wave. You see this T is upright, is round. So for one that has hyper, you'll find this T almost getting to be on the same level as the QRS complex. Sorry for that. So this is a P, Q, R, S, and then you have the T. So for hyperkalemia, you'll find this T wave tends to go up, and then it is almost the same level as the R wave. That's why the meaning of the word tall peak T waves, a distinctive feature of hyperkalemia. For the P wave, supposed to be round facing up. You find that in hyperkalemia, sometimes it tends to be flat. So instead of it being this way, it is somehow flat. Another thing, we have widened QRS complex. This is the QRS complex. It tends to be wider. And lastly, we have prolonged PR interval. Prolonged PR interval. From this distance all the way to the Q is prolonged. So I don't want to go to the ECG analysis, but for a normal PR interval, supposed to be between 1.2 to 0.2 seconds. So in hyperkalemia, you'll find that this distance or this interval will be elongated. Now let's talk about the management. So with priority questions in Nclex, you may be given various management, and all of them are done to a patient, can be done on a patient with hyper. But the priority is to administer calcium gluconate. I know during the shifting, you normally use the three of them at once, or normally do them continuously. But if it's listed separately, then this will be the priority, because you want to prevent the dysrhythmias fast. And then that is followed by giving IV 50% dextrose and regular insulin. That is just to shift the potassium back into the cells. We also have the binding that is done by what we call polystyrene sulfonates, that is the caselate. And lastly, we have dialysis. So all these are methods of managing hyperkalemia. But I've said if you're given a priority question, then number one should be the priority. So I presume by now, if you get a question on hypo or hyperkalemia, you should be in a position to answer it, especially the ECG tracing. Now, away from that, we want to move to hyponatremia. hyponatremia. So here you're focusing on sodium, and here you say the sodium is going to be less than 135. So sodium imbalances are often linked with fluid volume imbalances. So mostly when the sodium level is affected, you'll find the blood pressure is affected. The brain cells are also affected. So the causes can arise from increased sodium excretion. For example, when someone sweats excessively, can arise from diuretic use, from vomiting, diarrhea, wound drainage, particularly from gastrointestinal, kidney disease, and decreased aldosterone secretion. Sodium losses can also arise from inadequate sodium intake. For example, when someone is on MPO status, whenever there is low salt intake or salt diet. Or it can arise from dilution of serum sodium. For example, excessive ingestion or irrigation with hypotonic fluids, from kidney disease, freshwater drowning, in SIDH, and heart failure. All these are causes of hyponatremia. And when the level goes below 125, the patient can start convulsing, they can go into coma, and that can result to death. So you may find a patient with 133 and they are still normal, or they don't have any symptoms. But the moment sodium is way reduced, then there is a problem somewhere. The patient can start convulsing. So let's look at the assessment. Again, sodium is a key electrolyte. And so when it's affected, most of the systems are also affected. So for the cardiovascular system, the symptoms vary depending on the vascular volume. For example, in normovolemia, there'll be a rapid pulse with normal blood pressure. In hypovolemia, there'll be a steady, weak, rapid pulse, hypotension, flat neck veins, normal or low central venous pressure. In hypervolemia, there'll be a rapid bounding pulse, normal or elevated BP, normal or elevated central venous pressure. So the symptoms vary depending on the vascular volume. On the respiratory system, we have shallow, ineffective respiratory movement, and this is a late sign due to skeletal muscle weakness. For the CNS, hyponatremia will cause generalized musculoskeletal weakness with more pronounced in extremities. So there'll be a diminished deep tendon reflexes. In the CNS also, we have headache, confusion, seizures, and coma. And I've said this will occur especially when the levels start to decline less than 125. In the GIT, a patient presents with nausea, increased motility, and hyperactive bowel sounds. In addition, there'll be cramping and diarrhea. In the neural system, we have increased urinary output. In the interjumentary, that's the skin, it will be dry. There'll be presence of dry mucous membrane. And of course, laboratory findings, you say less than 135. And for specific urine gravity, it will be decreased as well. So what's the management? So you need to accurately monitor body system related to the impact of changes in serum sodium status. Also take note of the drug the patient is taking that are likely to contribute to this. So if a client is taking lithium, you monitor lithium levels because hyponatremia can cause diminished lithium excretion resulting to toxicity. We also have management in terms of dietary intake that should be increased. For example, Foods such as bacon, butter, canned foods, luncheon meats, table salt, all those are high content of sodium. Also, we monitor the intake and output. We monitor daily weight and neurovascular status. Also, you assess the serum sodium levels closely. I said when the levels decrease to less than 125, the patient may start um, convulsing. So you need to initiate seizure precaution. And what are some of the seizure precautions that we give to a patient with any condition that may present with convulsion? What are some of the seizure precautions? Highly testable when it comes to Nclex. Still waiting to get your feedback. I'm going to repeat the question again. Can you mention some of the seizure precautions? Keeping the bed at the lowest position, that's correct. That's one of them. Airway protection, that means you need to loosen anything that is tight on the airway. Ensure the patient environment is safe. Remove any harmful objects. You do not try to put any spoon, a tongue depressor in the teeth of the patient. You need to have oxygen available, but remember you only use them after a convulsion. You don't start giving during a convulsion. Another precaution is positioning. You position them on the lateral position after a convulsion. Never try to restrict them on the ground. Don't hold them during a convulsion. Those are key points to remember. Under seizure precautions, you're likely to get a question on that. So you're saying you need to be ready to initiate, especially when the levels are too low. Also, you need to provide safety on the patient. You provide fall precautions, especially when they are confused and then they are weak. And you educate about restriction of fluids if it is from dilutional. And you monitor some of the medications, such as diuretics and the selective serotonin reuptake inhibitors. So it's about hyponatremia. So the opposite is hypernatremia. About ECG changes, sodium does not affect the ECG. So that's why we do not have an illustration of ECG. Both hyper and hypo do not alter the ECG. So for hypernatremia, this is when the levels are above 145. And some of the causes include decrease in sodium excretion. For example, on corticosteroid use, prolonged Cushing syndrome as a disease, kidney disease, hyperaldosteronism. Also, it can come from increased sodium intake. For example, when someone takes oral sodium in excess, administration of sodium containing IV fluids, we mentioned about it, the hypertonic solutions. And then also you have a decrease in water intake, either when someone is fasting or on NPO status. And then lastly, you have increased water loss. For example, when there's increased metabolism, when a patient is having fever, they're losing water, when they're hyperventilating, when someone has an infection, when they're sweating excessively, following diarrhea and diabetes insipidus. All these are likely to cause hypernatremia. So again, on the assessment finding, to affect the same systems. So for cardiovascular system, heart rate and BP responds to vascular volume status depending. It varies. For respiratory symptoms, you have pulmonary edema, which may be present if there is hypervolemia. In the neuromuscular symptoms, early signs include spontaneous muscle twitching and irregular muscles contractions. For late signs, we have skeletal muscle weakness with diminished or absent deep tendon reflexes. In the CNS, hypernatremia will cause altered cerebral function, and that's the most common sign. There may be normal volemia or hypovolemia, where a patient presents with agitation, confusion, and even seizures. For hypervolemia, a patient may present with lethargy, stupor, and they can go into coma. For renal symptoms, there's a decrease in urinary output. In the integumentary symptom, there's a dry and sticky tongue with dry mucous membrane, dry and flat skin. Edema may or may not be present depending on fluid volume. In the GIT, one experiences extreme thirst. And then for labs, we have sodium more than 145 and increased urinary specific gravity, whereby the urine that's being produced is very much concentrated. So let's look at how you intervene for hypernatremia. So you need to prepare to administer IV solution to restore fluid balance. And here you can administer hypotonic solution. A good example is the D5 dextrose in water. We talked about that it's normally isotonic, but the moment you administer it, it becomes hypotonic. Also, for the inadequate renal excretion of sodium, you administer diuretics to promote sodium loss. You need to restrict sodium and fluid intake. Also, you need to monitor the blood glucose closely as you give this dextrose in water. I've said is one of the examples of hypotonic solution that can be used to manage hypernatremia. So as you give it, and actually if you're dealing with a patient who's diabetic, you have to monitor the blood glucose closely because it can result to hyperglycemia. So that is about sodium. Next, we want to move to calcium. So we'll start with hypo and then we move to hyper. So I just want to ask, what can cause hypocalcemia before I present that slide? What can cause hypocalcemia? Low calcium. Low intake, removal of parathyroid gland. That's very good. Uh, Menopause. So there's usually a procedure that is done to thyroid. You may find this question, and it's common in Nclex. A patient has undergone thyroid removal. We call it thyroidectomy. Thyroidectomy. What happens? Which electrolyte anomaly follows thyroidectomy? Which electrolyte abnormalities follow thyroidectomy and how does it come about? So thyroid gland, you know what thyroid gland is? Normally looks like a butterfly. And then we have, this is the thyroid gland. And then you have posteriorly, we have what we call the four parathyroid glands. These ones. So when you remove this, whenever a patient is undergoing thyroidectomy, meaning the removal of this, actually the parathyroid gland, they can go together with the procedure or they can be injured in the process. And parathyroid hormone, of course, the one that is secreted by the parathyroid gland tends to be affected and is the one that's responsible for controlling our calcium levels in the body. So you'll find that during thyroidectomy, a patient may develop hypocalcemia. So we're going to look at the signs and symptoms, but this is just one of them. There are many other causes, but this one I know tends to be tested quite a lot. Complications from procedures, those ones, they must be on your fingertips. So hypocalcemia is when the levels is below 9. And you know that calcium is normally stored in the bones, okay? It's absorbed in the GIT system and is excreted by the kidneys. It's stored in the bones. So when someone has issues with the bones, when someone is maybe on bed rest, what tends to happen? More of it will be stored, or more of it will be broken down and channeled to bloodstream. So most of it will be stored, leading to hypocalcemia. Calcium is controlled by PTH, parathyroid hormone. And you'll find that calcium and phosphorus, they normally go in opposite direction. Phosphorus and calcium, they tend to go in opposite direction, whereby if calcium increases, phosphorus will decrease. It's an inverse relationship that they have. So later on, if we get to discuss about hyper and hypophosphatemia, you'll find that a patient who has low phosphorus levels, they present with symptoms of hypercalcemia. And a patient who has hypocalcemia, like the way we discuss right now, they'll present in the same manner as a patient who have hyperphosphatemia. So they have an inverse relationship. So calcium is controlled by both parathyroid hormone as well as vitamin D. So let's start by looking at the causes of hypocalcemia. So number one, from inhibition of calcium absorption from the diet, the GIT tract, sorry. For example, when someone has inadequate oral calcium intake, give me sources of calcium. Give me examples of dietary calcium. So milk, dairy products, that's a good source of calcium, bone soup. So you'll find that for individual who has not been taking calcium sources, then they'll suffer from hypocalcemia. Lactose intolerance, you say that the major source is milk and milk products. So for an individual who cannot tolerate lactose that is coming from milk, then they'll suffer from hypocalcemia. Also, you have malabsorption syndrome like celiac disease, Crohn's disease, where they present with diarrhea. So they're getting rid of their calcium from the body, inadequate intake of vitamin D. It can also arise from calcium excretion, calcium excretion, like kidney disease, especially during the polyuric phase, where there is massive loss of urine output. And then also you have diarrhea and steatorrhea, J wound drainage. Can arise from conditions that decrease ionized calcium, like during binding of calcium and in condition like acute pancreatitis. Additional causes include hyperphosphatemia, because I said phosphorus and calcium, they have an inverse relationship where one is elevated, the other one drops. So in this case, phosphorus is elevated, so calcium will be low. Then lastly, we have removal or destruction of parathyroid gland. I've just explained about it, especially it occurs when an individual is undergoing thyroidectomy. So let's talk about the signs and symptoms. The signs and symptoms. Again, you can see there are various systems that are affected, and I'm going to start with the cardiovascular system. So there'll be a decrease in heart rate, hypotension, diminished peripheral pulses. So you normally say with hypo, it's like everything is normally on the lower side. Decreased heart rate, decreased blood pressure, decreased peripheral pulses. Everything tends to slow. In the neuromuscular effects, we have anxiety, irritability, and irritable muscle results to twitching, cramping, tetany, and seizures. We also have hyperactive deep tendon reflexes, paresthesia, that is numbness affecting the limbs, the nose, the ears, and the limbs. And then you have two signs that you're coming across. The first is called Troughs and chopstick sign. Very important to remember. Troughs and chopstick sign. So allow me just to show you the two, and then we'll come back to look at the other effects. So remember, chopsticks has a C. So that is on the cheek. And then trough sign affects the hand. So let me say what happens. So in chopstick sign, whenever you tap on the facial nerve, this is where the facial muscles are, and there we have the facial nerve. So if you tap on a patient who has hypocalcemia, and you tap on the facial nerve, on the muscles, we respond by twitching. So we have twitching of the facial muscles in response to tapping over area of the facial nerve. So it can be tested in this manner. A patient who underwent thyroidectomy and now they're presenting with twitching after tapping over facial nerve. There, the electrolyte that the patient has is hypocalcemia as a complication of thyroidectomy. What about the trough sign? What happens? So this one, you normally check the blood pressure on a patient, you apply the cuff, and then you inflate. Like that's the normal way of checking the BP. So what happens when you inflate the blood pressure cuff? The patient presents what we call carpopedial spasms. Carpopedial spasms. So if you check on this, they tend to turn inwards. This is what we call carpopedial spasms. So whenever you apply pressure or you take the blood pressure of a patient, and then you find that the fingers are curving inwards, these are carpopedial spasms, that is trough sign. Those two are very tested. Remember, they occur in hypocalcemia. They can also occur in each other electrolytes. For those ones who've read, which other electrolyte presents with their troughs and subtext sign besides calcium levels being low? Which other one? Which other electrolyte abnormality will a patient present with the two? Hypomagnesemia. Also in hypomagnesemia. So those two, a patient is likely to present with troughs and chopstick sign. So if you don't see calcium and you have hypomagnesemia, then go for that. So let's proceed on the other assessment. So I've highlighted these two because whenever you come across a new term, always take note of it. So that is on the neuromuscular effects. On the GIT, we have increased gastric motility. We also have hyperactive bowel sounds, cramping, and diarrhea. And then on the respiratory effects, these are not directly affected, though there may be a risk of respiratory failure due to muscle tetany or the convulsions. For the renal effect, the urine output varies depending on the cause. And then for laboratory findings, especially on the ECG, the ECG is affected. I say the only one that does not affect ECG is sodium. So here we have prolonged ST interval, prolonged QT interval, prolonged ST interval, prolonged QT interval. This is P, that is Q wave, that's the R wave, that's the S wave, that's the T wave. So you're saying that the distance between S to T will be prolonged. Essentially, the distance between the Q, the T wave will also be elongated. Okay? Those are the ECG changes that occurs in hypo. That means in hypercalcemia, these two will be shortened. In hypercalcemia, the ST and the QT interval will be shortened. So how do you manage for this? So we start by administering calcium supplements, either orally or IV, depending on the degree of calcium level. So when you're giving IV calcium, for example, if you're giving IV calcium gluconate, it needs to be warm to body temperature, and it should be administered slowly as you monitor for ECG changes. Also, you watch for infiltration and you prevent hypercalcemia. Again, checking on the rate of administration and the dose. Because again, you can correct one problem and you cause another problem. We also have medication that can be used to increase calcium absorption. For example, you have aluminium hydroxide, which reduces phosphorus, and that will increase calcium. We also have vitamin D, which enhances calcium absorption from the intestines. You need to nurse these clients in a quiet environment to minimize environmental stimuli, because you say that they can present with convulsions. And you initiate seizure precaution. We talked about them, and I've said those should be on your fingertips, the seizure precautions. You monitor for fractures, you move the client carefully, and you watch for pathological fractures. And then if you're using calcium gluconate, you need to keep the 10%, especially for acute calcium deficit. And then lastly, we have the dietary management, where you treat the patient to take diet rich in calcium. For example, the dairy products, leafy green vegetables, cheese, milk, soy milk, fish like sardines, spinach, tofu, and low-fat yogurt. All those are good sources of calcium the patient can benefit from. So I say that calcium and phosphorus, they have an inverse relationship, whereby when you reduce one, you increase the other. And that's why you're using aluminium hydroxide. Okay? It will reduce phosphorus, but when you reduce phosphorus, you're going to increase calcium. And so you'll have corrected for hypocalcemia. So let's talk about hypercalcemia. Hypercalcemia. And this is when the calcium is above 11. And we start by looking at the causes. So one of the causes can be arising from increased calcium absorption through excessive oral calcium intake, like those products that you talked about, or even giving too much of calcium supplements. It can arise from excessive oral intake of vitamin D. Remember, vitamin D helps to absorb calcium. Hypercalcemia can also come from decreased calcium excretion, especially when the patient has kidney failure. The calcium tends to be retained in the body because the kidney are not able to excrete them. Also, you have the use of thiazide diuretics. Another cause is increased bone resorption or bone breakdown. For example, in conditions like hyperparathyroidism, hyperthyroidism, in malignancy, bone malignancies, and immobility. So when someone is immobile on bed rest, they're likely to have hypercalcemia. And then lastly, from hemoconcentration, for example, when someone is dehydrated, when they with the use of lithium and with adrenal insufficiency. So by now, I hope you remember the signs for hypo. They're going to be the opposite in hypercalcemia. We'll start with the cardiovascular effects. There'll be an increase in heart rate early and then later on to lead to bradycardia. There'll also be an increase in blood pressure. The pulses will be bounding and increased. And how did I say we document when there is bounding pulses? How is it documented? We document it as 4 plus. Good. We document it as 4 plus. So if they've written a patient's pulse is, let's say, 104 beats per minute and 4 plus, then you don't go asking what does 4 plus mean. It means it is bounding. On the respiratory effects, there'll be ineffective respiratory movement due to skeletal muscle weakness. In the neuromuscular effects, one will become disoriented, lethargic, and even can go into coma. There'll be a profound muscle weakness with diminished or absent deep tendon reflexes. And then the renal effects, we have urine output that varies depending on the cause. In the GIT, there'll be a decreased motility, whereby the bowel signs will be hyperactive. The patient will also experience anorexia, loss of appetite, that is, nausea, abdominal distension, and constipation. And then on the ECG, who remembers the one for hyper? Sorry, for hypo, we said it is? For hyper, we said the ECG will be prolonged. Now, the ECG for hypercalcemia, it looks like this. Number one, shortened ST segments. This is shortened, and the QT interval is also shortened. Another thing is this T wave is wide. Okay? The T wave should be something like this. But in this case, with the hypercalcemia, it is wide. So someone is asking, why do you have, just allow me to read the question. Why is there muscle weakness with high calcium levels? So when the calcium levels are high, what happens is that it raises the threshold for nerves as well as muscle stimulation. So the neurons, they become less excitable, okay? And so it becomes very hard for the nerves to fire to trigger a contraction. Remember the role calcium plays in muscle contraction. So basically, just to quote, it causes what we call a depressed nervous system. That's why we have the muscle weaknesses. So let's talk about the intervention for this patient who presents with hypercalcemia. So going to administer isotonic saline solution. You discontinue calcium containing IV fluids or oral medications with calcium or vitamin D. Also, you can discontinue thiazide diuretics and you replace them with diuretics that enhances calcium excretion. We have some drugs that are used to lower calcium levels. For example, you have the calcitonin, we have the biphosphonate, and you'll find patients with who are at risk of fractures or osteoporosis are normally put on this drug, the calcitonin, the biphosphonate. So they inhibit bone breakdown or what you call bone reception. You also have the use of phosphorus, and I hope you can see the relationship. When you give a patient phosphorus, what do you do? You bring about low calcium levels. So that's how it can be used. And then you have the use of prostaglandin synthesis inhibitors like aspirin and the NSAIDs. Dialysis also can be done in cases of severe hypercalcemia despite the drugs. Other management, we have pathological fractures. So you move the client carefully, you assist with ambulation, and you monitor for signs of fractures. Also, you monitor for urinary stones. Part of the assessment for kidney stones that comes with high calcium levels include flank or abdominal pain. Also, you need to strain urine, checking for all stones. The most common stone that causes kidney stones is from calcium. And then you have dietary recommendation. The patient should avoid taking foods high in calcium. So instruct the client to avoid foods like dairy products, the sardines, the green leafy greens that contain high calcium levels. So the next one is hypophosphatemia. So we're moving to phosphorus, and I hope you remember the relationship. So basically, when you talk about phosphatemia, hypophosphatemia, when you talk about hypophosphatemia, basically, what are you going to be discussing here? The patient will be presenting with features of, when you talk about hypophosphatemia, low phosphorus levels, the patient will be presenting with features of, the patient will be presenting with features of hypercalcemia. The patient presenting features of hypercalcemia. So I will not go through them again. Remember, I said phosphorus has an inverse relationship with calcium, in that when phosphorus is low, calcium is elevated. So we talked about hypercalcemia. So the features of hypercalcemia this patient will present with. But let's look at the causes. And you're saying here there's a decrease in phosphorus level is accompanied by an increase in calcium levels. And here the level of phosphorus is less than 2.5. So phosphorus itself plays a major role in cellular metabolism as well as energy production. It makes up what we call the phospholipid layer of the cell membrane. And the large component of phosphorus, which part of our body contains high level of or is made of phosphorus? Phosphorus. They are high in the teeth as well as the bones, the teeth and the bones, just like uh, calcium. And I say they have an inverse relationship with calcium. So on the causes of hypophosphatemia, number one, they can be coming from insufficient phosphorus intake. For example, when someone is starving, so they're not taking enough phosphorus, or they are experiencing malnutrition. Alternatively, they could be coming from increased phosphorus excretion. That means the body is losing or wasting a lot of phosphorus from urine. For example, in hyperparathyroidism, in malignancy, alternatively, the use of magnesium-based or aluminum hydroxide-based antacids. And then thirdly, we have intracellular shifts. For example, in hyperglycemia and in conditions like respiratory alkalosis. All this can lead to low phosphorus levels. So I don't want to go through this once again because these are just the same things that happen in uh, in hypercalcemia. It's basically what we just discussed previously. So I will not go through them again. But of interest is on the management, in the management of hypophosphatemia. So number one, you need to discontinue the contributing medication, for example, antacids. You can give oral phosphorus and vitamin D supplements. That is to improve absorption of phosphorus. In severe cases, you may need to administer IV phosphorus. And that is when the phosphorus level go below 1 milligrams per deciliter. And as you do this administration, also you monitor closely for hyperphosphatemia. Always assess the renal function before you administer phosphorus. Also, you carefully monitor for pathological fractures, especially in severe cases. And lastly, you also increase phosphorus-rich foods and you decrease calcium-rich foods. Remember the inverse relationship. So there's not much in phosphatemia in terms of ECG changes. And then you have the hyperphosphatemia, and that is when the level is above 4.5. So in this particular one, we'll be discussing features of hypocalcemia. The assessment will be for hypocalcemia. The assessment will be for hypocalcemia. But let's talk by definition. This is when the serum phosphorus is above 4.5. And an increase in phosphorus is accompanied by a decrease in calcium levels. Some of the causes include a decreased renal excretion. For example, a patient who has kidney failure, they not be excreting phosphorus in urine, leading to buildup in the bloodstream. Conditions like tumor lysis syndrome to also lead to an increase in phosphorus levels. I'd like to hear from you. What are the other electrolyte abnormalities in TLS? TLS, tumor lysis syndrome. I know you're not covering oncology, but it does not harm for us just to remind ourselves about TLS. Tumor lysis syndrome. What are the other electrolyte abnormalities? Before I go ahead to say what it is all about. Let's start by looking at what is TLS. So number one, this is a complication from treatment of cancer. Okay. So when the cancerous cells are destroyed by chemotherapy, and actually you don't go ahead to hydrate. You'll find that before chemo, we hydrate the patient. After chemo, we also hydrate to prevent what we call TLS. So when there is rapid breakdown of the cells, especially the red blood cells, it leads to release of some electrolytes in the bloodstream. Okay? So some of the electrolyte abnormalities in this condition, and it's usually life-threatening, we have hyperkalemia. The other one is hyperphosphatemia. This one, hyperphosphatemia. And you remember when phosphorus is elevated, we have hypocalcemia. And lastly, we have hyperuricemia. Hyperuricemia, high uric acid levels. So you can go read more about it, but the management is usually to give IV fluids. You rehydrate the patient before chemo and afterwards. So of interest here is on this one. Phosphorus levels the levels are rising because of this condition TLS, but you can go read more about it. And then thirdly, it can arise from increase in phosphorus intake. That include dietary intake or overuse of phosphate-containing laxatives or enemas. And then lastly, from hypoparathyroidism, whereby there is reduced calcium levels, and that can result in increase in phosphorus. So I said here in hyperphosphatemia, there's a decrease in calcium levels. So on the assessment, these assessments are equally related to hypocalcemia. So I will not go through this again. We just talked about it earlier on. Now let's talk about the intervention. The intervention. So remember, the patient is presenting with hypocalcemia. So you have to manage for hypocalcemia. So interventions focus on restoring calcium levels due to the reciprocal relationship between calcium and phosphorus. We have the use of phosphate binding drugs, which will be administered to increase fecal excretion. For example, Sevalama. We also have dietary restriction of phosphorus containing foods. Avoid phosphate containing medications like laxatives and the enemas. And then for medication instructions, educate the client to take phosphate binding medication with meals or immediately after meals. So I've said a drug that can be used to bind to phosphate. A good example is sevelamer. So this sevelamer should be taken with meals or immediately after meals so that it binds to the phosphorus. So the last electrolyte of focus is magnesium, and we start with hypomagnesemia. Hypomagnesemia occurs when the magnesium level is less than 1.5, that is in the blood. And some of the causes include from insufficient magnesium intake, like when someone is starving, during vomiting and diarrhea, you lose magnesium. Malabsorption syndrome, like Crohn's disease or celiac disease, you lose magnesium. Then it can also arise from increased magnesium excretion. Some drugs, like diuretics, can lead to loss of uh, magnesium very fast, and chronic alcoholism. Other causes arises from intracellular movement of magnesium in cases of hyperglycemia, insulin administration, and sepsis. So let's look at the assessment for hypomagnesemia. So in the cardiovascular effects, we have tachycardia and hypertension. In respiratory, a patient presents with shallow respirations. In neuromuscular effects, we have hyperreflexia, that is increased deep tendon reflexes. We have twitching and paresthesia. Remember the Trough's and Chopstick sign, they are positive. So I said hypocalcemia, hypomagnesemia. The patient presents with positive Trough's and Chopstick sign. And then lastly, tetany and convulsions can also occur. In the CNS, one presents with irritability and confusion. So how to intervene? You need to restore calcium levels. You'll find that many a times when calcium is uh, decreased, even magnesium levels tend to be decreased. So the calcium levels needs to be normalized. We also have administration of oral magnesium preparations. But you need to take note that they can cause diarrhea, and that can lead to further magnesium loss. And then you have administration of IV magnesium sulfate. So this is given in severe cases. IM injections are avoided due to pain and tissue damage. For those of us who have given magnesium sulfate, for example, while you are managing for preeclampsia, we know that whenever you give the magnesium sulfate, you normally use, you add water at the end of it, you draw your magnesium sulfate, and then what do you add? What is added to that syringe before you give the magnesium sulfate? You normally add lignocaine because of that pain that comes with the administration IM. They're saying if possible, avoid giving it IM. So as you're giving it, you have to monitor for Shiza. You monitor the magnesium levels, and also you monitor for deep tendon reflexes. Remember, one can develop adverse effect from magnesium when the levels are elevated. So what do you normally watch out for? Especially for those of us who've given magnesium sulfate before. There are three things that you normally watch out, very important as you give magnesium. What do you look out for? In other words, what are some of the adverse effects of magnesium? The respiratory rate, very important. Urine output and deep tendon reflex. What happens to deep tendon reflex? It diminishes or they become absent. What about respiratory rate? It may go less than 12. Urine output may diminish. So as you're giving to correct hypomagnesemia, also need to be on the lookout for the opposite effects or the adverse effects. And then the last management, we have dietary sources. So the patient need to increase intake of magnesium-rich foods. For example, green leafy vegetables, we have the nuts, the seeds, and whole grain. So as I wind up, we talk about the hypermagnesemia, and this is when the magnesium is above 2.5. Some of the causes of hypermagnesemia come from increased magnesium intake, when someone's taking magnesium-containing antacids or laxatives, or whenever you're giving IV magnesemia to correct hypo, it might lead to hypermagnesemia. In addition, when there is decrease in renal excretion, a patient who has kidney failure, they may tend to retain the magnesium. On the assessment, a patient presents with bradycardia, which may lead to dysrhythmias or even cardiac arrest if severe. We also have hypotension. In the respiratory system, we have respiratory insufficiency due to involvement of skeletal muscle. In the neuromuscular system, there'll be diminished or absent deep tendon reflexes, accompanied by weak skeletal muscle. And then in the CNS, a patient presents with drowsiness and lethargy, which may progress into coma. On the interventions, we have the use of diuretics to increase renal excretion of magnesium. Also, you have the use of calcium gluconate or calcium chloride IV, administered to reverse the effects of magnesium on cardiac muscles. Remember, as you give magnesium sulfate, in case of toxicity, you normally have an antidote, and the antidote is calcium gluconate. And then also on the dietary restriction, you need to instruct the client to restrict dietary intake of magnesium-containing foods. They should avoid magnesium-containing antacids and laxatives. And then last but not least, you educate them to avoid the use of laxatives, use of antacids that contain magnesium to prevent further magnesium buildup. So that is what I had for us for today about fluid and electrolytes. And out of the discussion that you've had, to summarize the key electrolytes, we have potassium, commonly tested, calcium, as well is commonly tested, sodium, not as much, but it's important just to know. Magnesium, you may find a question, one question on it, but these two are the key electrolytes, and especially potassium. So due to interest of time, I'm going to stop at that, and I want to take it back to Ruth. Thank you for listening. If you have any questions, you can actually post them. I'll be able to answer. But for now, Ruth, I take it back to you. Ruth, are you there? Sylvia, are you there? I take it back to you. All right. So someone is asking, can we get this recording? The recording is normally available for the paying students, those ones who were enrolled for the program at the portal. Usually uploaded like the next day. All right. So if there are no more questions, we're going to stop at that. So there was a link that was shared earlier on. You can always fill that form if you like to join our passcode. And then from there, you'll be guided on how to go about our classes in terms of our payment. So there's a form that was shared. Should you have any inquiries, please Kelly, you can go through the charts. There's a form that was there. So if you have any inquiries, any concerns, you can always fill that and then someone will be able to reach out to you concerning our program. You'll be enlightened more about our cost and everything pertaining the Nclex program. Otherwise, feel most welcome. We normally have these sessions at least once in a month. So be on the lookout on the next topic. And always suggest the topics that you feel you're inadequate of so that you can always line them up for revision. Other than that, I wish you all the best in your revision. For those ones who want to make a bold step on joining, feel most welcome and bye for now.